because and you only came to one lecture in my entire class, well, this is probably the best one to sit on because it actually goes through about everything that we talked about again in a little bit simpler language. So I actually enjoy giving this one. I hope that you enjoy listening to it. So when I get the thumbs up, we will get started. All right, so we're going to be talking about managing HIV infection and ARVs. This is sort of an overview or a review of some concepts we've already talked about. Some things we go into a little bit detail, and we're previewing some of the things that we're going to see later on. So this is a good place to put this lecture in sort of the middle of the course because it's a bit of a review and a little bit of a preview for the rest of the course. Okay? So what are we going to talk about in this lecture? It's a little bit of everything. We're going to talk about how does HIV make you sick, which we talked about a little bit in the pathophysiology lecture. How does HIV work? Also talked about in the pathophysiology lecture. What are the ARVs that are available in South Africa compared to ARVs that are available in some other countries? And what is resistance? We always talk about this resistance thing with HIV. So what is it? How does it happen? And how does it occur? And how do we deal with it? And so that goes hand in hand with resistance is why is adherence so important to therapy, antiretroviral therapy. Okay, so that's what we're going to be talking about in this lecture. So, what is this guy? The Masosha, right? The soldier of the body. This is your CD4 cell count, whose job is to protect you, right? To keep you safe, keep you healthy. When other things are trying to invade the body and make you sick, it's the job of the Masosha, of the soldier of the CD4 cell, to protect you and keep you healthy. And then another analogy that we saw before is the train of life analogy. Right? Once you become infected with HIV, your life is like a train running down a track. Right? And at the end of the track, there's a cliff. So once the train falls off the cliff, that's when the person dies. So a very good analogy of what HIV is like in the body is this train going down a track that's going to fall off the cliff. And we use certain things to measure how a person is doing when they're HIV infected. Similar that we can describe this situation. So one would be the distance of the train from the edge of the cliff. And that's analogous to a CD4 count. So how close is the person to the edge of the cliff? How advanced is their HIV? How likely are they to get opportunistic infections, get sick, and potentially die? And another thing that we look at is the viral load. The viral load is analogous to the train's speed. How fast is the train going? So for adults, this analogy works very, very well. Because a person might have a very low CD4 count, but the train is slowing down and stopping because they're on ARVs. And not only do ARVs slow down and stop the train, but they actually back it up because your CD4 count gets higher and higher and higher as you're on antiretroviral therapy. So this becomes a very good analogy of what life is like for a person on antiretroviral therapy, or who is HIV infected. Without antiretroviral therapy, the train is still going. Without ARVs, the train is still moving forward towards the edge of the cliff. And the viral load can tell us how fast is that train moving. And we've seen this time and time and time again. And because it's very, very important. This also is another way to describe what it's like and what's happening inside the body in a person who's HIV infected. So the blue represents the CD4 count, and the red represents the viral load. So and this is again for adults. What happens in adults who are infected with HIV? Well, as you see in the first few weeks, really in the first 2 months, the CD4 drops dramatically, drops by almost half of where it should be, over 1,000. and it drops to around 500 in the first few weeks that you're HIV infected. And a similar thing is happening with the viral load. When you were uninfected, you had an undetectable viral load, and then you quickly reach levels of viremia of 100,000 copies per milliliter. Okay, so lots of virus floating around in the blood. This is a time when patients who are infected are very contagious. If they're continuing the behaviors that got them infected in the first place, having sexual intercourse unprotected with multiple partners, well, they're likely spreading it around. If they're continuing to use IV drugs, they're likely to be spreading it around. So behaviors that likely got the infection are likely continuing during this period, causing a very much expansion of the HIV virus. And the transmission rates are very high during this time period. This is the time period we talked about of acute infection and acute seroconversion. So during this time, most of the rapid tests that we use will be negative. Patients may experience symptoms that are like the flu. They'll get fever, headaches, not feeling well, body aches. They could have cough, runny nose, all these sorts of things. They go to the clinic. They get told that they have the flu. They say, oh, but wait, this might be HIV infection. So the counselor says, okay, well, let's do an HIV test, and it's negative. So the counselor tells them, you're HIV negative. But in fact, they're not. In fact, they're not. So with a reinforcement of a negative test, again, they might go out and continue the behavior that got them infected in the first place. Again, contributing to the transmission of HIV. So then what happens? Patients reach this stage called clinical latency, where HIV is continuing to replicate in the body, and the patients sort of are at what we call a set state. The viral load eventually drops down to a certain level and slowly climbs with time. And the CD4 count slightly rises after the precipitous drop, comes back up a little bit, and then again slowly with time continues to decline until it reaches a point where the body can no longer fight off infections that it normally could. And that's the point where opportunistic infections can take place. Patients start to get symptomatic. Patients get sick. And without treatment, eventually the patients would die. And so that's what happens to an adult infected with HIV without antiretroviral therapy. And again, this is the structure of HIV. This is what it looks like, and so or a picture of what it looks like. And so why do we need to know this? Because this is very important as to what a lot of our tests use to detect it, and what our medicines use to try to fight it. So these proteins that stick out, these yellow and green cartoons of the proteins that stick out, are what antibodies are formed to. So antibodies are the body's labels of good guy versus bad guy. So antibodies, the immune system, the defense system's way of labeling something a bad guy. And this is what the antibodies are made against. It says if you see these yellow and green sticks sticking out of it, that's an HIV virus, and that's a bad guy. And then there's the enzymes. There's reverse transcriptase, integrase, and protease. And these are where our ARVs work. These are where the drugs go in to destroy the virus, to dismantle the virus, to stop the virus from making more of itself. And that's how antiretroviral therapy works. It simply stops the virus from making more of itself. If it can't make any more of itself, it will die out. There won't be a high enough level of virus in the blood to cause damage to the immune system. The immune system will restore itself, and patients will again become healthy. This is another cartoon showing where the medicines work on these particular enzymes. Remember, the NNRTIs work on reverse transcriptase, so Stokerin and nevirapine work on reverse transcriptase, and your NRTIs and your NTRTI, like AZT, D4T, 3TC, DDI, abacavir, also lumped into that group is tenofovir. They also work on the enzyme reverse transcriptase. They try to stop that enzyme from working, try to break it down, stop it, block it in a way, and then it doesn't work. So it can't perform its functions, so the HIV virus can't make more of itself. And then our protease inhibitor, Kaletra or Illuvia, works on the enzyme protease, which job is to package everything together so that it forms a mature virus that leaves the CD4 cell and goes off to infect other cells. Without that, it's just a pile of parts that don't work, it doesn't do anything, and it's not functional. It can't go off, it can't destroy the CD4 cell, and it can't go off and infect other cells. Okay. So some of the other new medicines, like the fusion inhibitors and the CCR5 inhibitors, work at this stage, where the virus binds to the CD4 cell. Okay? And without the HIV virus able to bind to the CD4 cell, then it can't enter the cell, and it can't infect the cell, so it can't destroy the cell. And there's new medicines also called integrase inhibitors, which block the HIV virus from taking the viral DNA or transcribed DNA and inserting it into the host human genome, host human DNA. And so then it can't perform its functions, it can't make its proteins to make new virus. So again, it stops the virus from making more of itself. If it can't make more of itself, it can't damage the cell, and it can't go off to infect other cells. So what are the primary goals of treatment? Well, the primary goals of treating HIV is the same as the primary goals of treating really anything else, of treating any other chronic disease like diabetes, like high blood pressure, like heart disease. All the same, is to improve the patient's health and prolong their life. The same is true with antiretroviral therapy for patients with HIV. Once a patient is on treatment, their CD4 count should rise above their baseline and stay that way. Their viral load should become undetectable, or at least to a level less than 400 copies per milliliter, by 6 months of treatment. So those are our primary goals. What is likely to occur if we are achieving these primary goals? Well, other secondary goals are likely to happen. As more people are on treatment, more and more people will see healthy people living long who are in fact HIV positive, which can lead to more people knowing their status. More people will test and be willing to test and be willing to take the medicines. As more and more people know their status, they'll also, hopefully, continue to practice safer sex methods using condoms. This would decrease transmission in discordant couples where one person in a relationship is positive and one is negative. As I said before, once somebody has an undetectable viral load on treatment, it's very difficult for them to pass on the virus. So in discordant couples, if a partner is on treatment, then it's very rare for them to pass it on to the uninfected partner. As more women get onto treatment, if they have undetectable viral loads at the time of conception, they're going to transmit the virus less to their children. And this, ideally, as we treat more and more people and decrease the amount of virus that's floating around in the community, this will decrease the number of new infections. So what is the effect of antiretroviral therapy? How does it actually work? What is its job? What does it do? Well, it simply stops the virus from making more of itself. That's all it does. That's all antiretroviral therapy, ARVs, the medicines we take. The only thing it does is it stops the virus from making more of itself. If the virus can't make more of itself, it can't destroy the CD4 cells. If it doesn't destroy the CD4 cells, the immune system doesn't get damaged, and it can actually have time to repair itself. If the immune system's doing fine now and repairing itself, this decreases the number of opportunistic infections, decreases the number of cancers, improves the patient's quality of life, and of course, prolongs their survival. But remember, it's not that easy. Patients do need to be monitored. Simply giving them a prescription for medicine doesn't stop the virus from making more of itself. They need to take it every day. And they need to take it on time every day. And we need to make sure that they're doing well, because there's also side effects of the medicine. So what should we monitor when somebody's already on treatment? Well, these are the things that I say that you should monitor every time you see a patient. Okay? You monitor how they're doing clinically. You look for signs and symptoms of disease progression. Are they losing weight? Are they getting sicker? Are they developing new opportunistic infections? Or are they healthy and fine and not having any symptoms at all? We also need to evaluate clinically for medicine toxicity, particularly those who are on stavudine, for peripheral neuropathy, for lipodystrophy, for lactic acidosis. Lots of the side effects. Those on tenofovir for kidney damage. So we need to monitor how they're doing clinically by checking how well they're responding to the medicine and also if there's any toxicity. We need to do some laboratory tests. We look at their viral response. Is the viral load undetectable by 6 months and remaining that way? Is their CD4 increasing? And is it increasing past baseline by about at least 6 months to a year? And in adults, it should go over 200, usually by about a year, and remain that way. We also need to monitor the patient's adherence, particularly the longer the patients are on treatment. Patients commonly want to take their treatment in the first 6 months to a year on treatment because most of the patients in South Africa were very, very sick by the time they started treatment, and so they want to get healthy. But what happens once they're healthy is they say, I'm healthy now. I don't need these medicines. I'm fine now. I feel great. I feel fine. I felt fine for the last 6 months. Why do I need these medicines? It's a very common thought process for patients, any patients who are on chronic long-term medicines and doing well. So we need to monitor their adherence, and you can do that through pill counts, through medicine calendars, through pharmacy refills. Are they coming to the clinic on time? Are they coming to the clinic at their scheduled appointments? Many ways to monitor adherence, but it should be monitored at each visit. And then continuing disclosure. Make sure they know about HIV, how it works, the ARVs, the side effects, how HIV is spread, what they can do to prevent transmission to other people. All of that is involved in disclosure. So what are our weapons in South Africa? What do we have available to us? Well, these are all the medicines that we have in the world currently, and highlighted in red, except tenofovir, is now available, are the medicines that we have in South Africa. So you can see the majority of the medicines that are available in the world, we actually have as part of the government program in South Africa. Okay. So these are the ones, and I've added tenofovir here, these are the ones that are available in South Africa. So most of the medicines that are used for first line and even second line throughout the world are here in South Africa. So we use the word HAART a lot, which stands for highly active antiretroviral therapy. What does that actually mean? Well, it means usually a combination of 3 drugs. And most regimens contain 2 NRTIs, so nucleoside reverse transcriptase inhibitors, and 1 of something else, either an NNRTI or a protease inhibitor. And that's really anywhere in the world, as first line is usually one of those. 2 NRTIs and 1 either protease inhibitor or NNRTI. So why do we use 3 drugs? Well, I'm going to show you examples of why we use 3 drugs in a few slides. But because it's been proven, 3 drugs decrease opportunistic infections, it prolongs life, it maximally suppresses viral replication, and it prevents resistance. So what is resistance? What do we mean by resistance? I'm going to demonstrate this for you in a few slides, but it's simply resistance is because errors are made when the virus is making more of itself. As I told you, the enzyme reverse transcriptase is a stupid enzyme. It makes mistakes all the time. And when it makes a mistake, it's an error. And that error is called a mutation. And mutations can happen anywhere in the virus. Some mutations actually make the virus weaker. But some mutations might make a particular ARV ineffective. And when there's a mutation that blocks the ARV from working, that's when resistance occurs. So that's what we mean by resistance. It's simply the virus has made a mistake when it was making more of itself. The mistake we call a mutation, and that mutation happened to be in a place where the ARV was working. So now it doesn't work anymore. So these mutations can occur anywhere. And if they occur in places where the medicine's not working, it doesn't matter. And usually it actually makes them weaker. But the problem is when this mutation happens in one of the enzymes. And remember, the enzymes that we use are reverse transcriptase, protease, and integrase. Those are the three enzymes or three machines that the virus must carry in with itself to make more of itself. Otherwise, it wouldn't be able to do it. And it needs all three of them. So if we can break one of these machines, if we can dismantle one of these machines, if we could stop one of these machines from working, the virus can't make more of itself. So these are what we target with antiretroviral therapy. Because if we can break down one of these enzymes, if we can stop one of them from working, just like stopping a machine from working on an assembly line or on a factory line, you don't get a finished product. It's the same thing with HIV. So now, if you are confused about mutations and errors in resistance, you won't be after the next two slides. Okay? I like to think of enzymes as machines because they perform one job. It's just like a machine on an assembly line. It comes, it does its function, and it moves on to the next phase. Just like a machine, it has parts, like screws, right? So ARVs are like a screwdriver, right? And if our screwdriver fits in the screws and we undo all the screws, what happens to the machine? It breaks, right? If you undo all the screws on a machine, is it going to work? No. That's exactly what is happening with ARVs and enzymes. Okay? So this is your HIV virus, and this is your ARV. The ARV comes in, it unscrews the machine, and the machine stops working. But what happens if, when they're building the machine, when the virus is making more of itself, there's a mistake, there's an error? And instead of using those screws, the screws change shape because it was a mistake, it was an error. So now what happens? If we have this screw with a square head, or the Phillips head, the plus sign, does this screwdriver fit in there? If we're trying to dismantle the machine with this screwdriver, will it work? So what is this? This is resistance. This is resistance. So what do we need? We need a new screwdriver, exactly. That's what second-line treatment is. It's a new screwdriver that can fit into these screws. That's exactly what is happening. So now this screwdriver doesn't work, or first-line ARV therapy doesn't work, or one of the drugs has stopped working because a mutation has occurred, the virus has changed its shape, and now where we go to dismantle it or to block it from working, it doesn't work anymore. That's how resistance works. That's how mutations work. And that's why HIV is very difficult to treat. So that's how it actually works. And here is another example. And most people, these two examples really explain, and I think most people find this an easy concept to understand. So all these circles represent an HIV virus. So what does an HIV virus do? It only has one job. It only wants to do one thing. And what's that? Replicate. Make more of itself. That's all it does. That's all it cares about, and that's all it wants to do. So our whole screen is the patient's body. Our dot is an HIV virus. So this person gets infected with HIV. And actually studies have shown that often it can take just one single virus particle to get you infected. It's a very small amount to get you infected. So that's what happens in this patient, okay? So we have an HIV virus inside the body. What does it do? It makes more of itself, right? But look what happened. It made a what? It made a mistake. Remember, on average, every virus makes somewhere between 1 and 10 mistakes when it's making more of itself. So already, the virus has been making more of itself. It already made a mistake. And what do these new viruses do? What's their job? To replicate, to make more of themselves. And look, we see a few more errors. And what's the job of these? To make more of themselves. And so on and so on and so on. But as you can see, this one made a mistake. And now we have some different viruses that have changed their shape a little bit. Maybe their enzymes changed. Maybe a different part changed. And then again, even those that already had a mistake can make another mistake. And then we see other ones that made mistakes up here and here. So the majority of the virus, most of the virus, looks like the original, doesn't it? The most of them are this light blue, right? And that's what we call wild type virus. So most of the virus floating around in the patient's body looks like the one that they got infected with. But there are others around, right? There are others floating around because it's always replicating and always making mistakes, always making errors, always making mutations. Okay. So now this is the person's body filled with HIV virus of all different types. What do they need? Well, how do we stop the virus from making more of itself? ARVs. Okay. Well, let's just give one. We'll give one ARV to this person, okay? And see what happens. In the early days of HIV infection, that's what we did. Why? Well, we only had one drug, and we didn't know any better. So we give this person AZT, the very first drug that there ever was for HIV. And what happened to people who took one drug? They got better initially, because what happened? It stopped a lot of the virus from making more of itself, didn't it? We just knocked out all the blue ones. But some of the viruses had different screws. Some of the viruses had already changed so that AZT won't work and would never work on them. And so what happened? These viruses made more of themselves and more of themselves, and soon they got sick again. So if you take one drug, you're likely to drop the virus down. You're likely to get better for some time. And then what comes? These viruses make more of themselves. Okay, so one drug, not a good idea, right? Well, what about two drugs? Now let's give the person another drug. Let's give them 3-TC. Okay? So now they take two drugs. What happens to the virus? Stops making more of itself, right? Stops making more. But there might be some that still have changed. And still, although we're taking two drugs, they've changed in two spots. So neither of those drugs work. So what happens if we take a third drug? We'll stop them all from making more of themselves. Because the likelihood that the virus has had changes in all three spots would be very, very, very low, right? Which means drug 1 didn't work, drug 2 didn't work, and drug 3 all didn't work. That would be pretty unlikely. But what happens, as is the case sometimes, if a person just takes two drugs? And this happens pretty frequently. People say, you know what? That's Stokerin. I took it for the first 2 days. I had terrible dreams. It was awful. I'm not doing that anymore. So they only take tenofovir and 3-TC. They say, I didn't seem to have any side effects from those medicines, so I'm just going to take those. 2 drugs, that's a lot. That should work, right? So what if there's one drug, one HIV virus in the body that's still not able to work, it's still able to replicate? So what's the job of this virus? To make more of itself. And what's the job of these new viruses? To make more of themselves. And these new viruses make more of themselves. And so on. And so soon, the patient's now getting sick, the viral load is high, the CD4 count is dropping. But hopefully we've intervened beforehand, right? The patient comes back at their 2-week visit in the clinic, right? And we do a pill count, and we say, whoa. 3-TC is fine, tenofovir is fine, but it looks like you only took 2 Stokerin. What happened? He says, oh, well, I had bad dreams, and I didn't make me feel right, so I didn't take it. I stopped it. And you say, no, you still must take it. Those side effects, they go away. Most people, after 2 to 3 days, there's no side effects. So they say, okay, I'll go back to taking it. Right? So this is our patient. He goes back, and now he's taking his Stokerin. And from now on, he met with an excellent counselor. He had counseling about resistance, about adherence. He's perfect from now on. For the rest of his life, he's not missing another dose. So what happens? He takes that 3rd drug, the virus stops replicating. Except that during that time period, there was another mistake, right? So now his adherence is perfect. He never misses a dose. He's on time exactly. When Generations comes on, he knows, it's 8 o'clock, it's time to take my medicine, right? But what happens to these viruses? They make more of themselves, and more of themselves, and soon we're left with a body full of HIV virus. Even though the adherence is perfect. But it wasn't for some time. Right? So, according to the current South African guidelines, we monitor viral loads every year. Do you see where that could be a problem? Do you see where that could be a problem if we're not monitoring adherence in our clinics? Because by the time we detect it, it's too late. For a year, the virus is making more of itself and more of itself and more of itself. And more mistakes, and more resistance, and more mutations. So this is why we take 3 drugs. If you take 3 drugs all the time, on time, you're left with no virus. Okay? So if you take 3 drugs at the beginning, starting early, and you already don't have resistance mutations, you're likely to have undetectable viral loads by 6 months. You're likely to stay healthy. And if you continue your treatment and not miss doses, continue with your good adherence, you can live a long and very productive life. Okay. Any questions about my dots?
So if it's undetectable, where is it hiding?
Excellent question. So the question was, if the virus is undetectable, where is it? How can it come back to life, right? Well, there's a couple answers to that question. When we say undetectable, it simply means our test that we're using right now doesn't find it. Doesn't mean it's not there. And there's brand new tests that are only used for research because they're very, very expensive. But it can go all the way down to detect 1 virus in a milliliter of blood. And when they took all these patients with undetectable viral loads, they thought, well, there's no virus, right? But when they used this special test, they said, no, it was there. It was low. It was like 4 and 5 and 7 and 10 and 12. But it's there, right? It's there. And then there's other places it can live. So we know that there is still viral replication, although it's very low if you're on treatment. And there's also other places it can hide. There's places where the body, the medicines don't get to very well. Particularly the main 3 are the brain, in men in the testicles and women in the ovaries. So the body has developed mechanisms to keep bad things out of those places, because those are pretty important places, right? Okay, we don't want to make mistakes and have things poisoning those areas. So the body has made a way to, if you ingest a toxin or medicine, a lot of the things that we take don't go to those areas. They're what we call sanctuary sites. So if HIV is there and living in those places, it can stay there and the drugs don't affect it very much. So that's the reason why we say undetectable, but it doesn't mean it's not there. You know, the analogy is like finding a needle in a haystack. You have a huge stack of hay and one needle in it. You could spend forever looking for that needle, and you're not going to find it. But does that mean the needle's not there? No, it's still there. It's still there. Okay. So what regimens do we use? Well, we now know that we've changed the regimen because of the toxicity of stavudine. We have new regimen 1 for adults. Okay. So regimen 1, as we said, almost all regimens in the world contain 2 NRTIs and something else. So our 2 NRTIs are lamivudine, or 3-TC, and tenofovir. And our 1 something else is Stokerin or nevirapine, and those are NNRTIs. And so that's the new initiating regimen for people in South Africa. 1B is what they've just changed the name to people who are already on treatment. So if you're on 1B, which is basically the same thing, but you're taking D4T or stavudine instead of tenofovir, if you're not having any side effects, then you just continue the treatment. If you are developing side effects, you should change the D4T for tenofovir. Some patients can't take tenofovir because of the main side effect of tenofovir is that it can cause kidney damage. And a good percentage of patients have kidney damage already because HIV can also damage the kidney. And lots of other things, and high blood pressure can damage the kidney, and diabetes can damage the kidney, and old age can damage the kidneys. So lots of things can cause damaged kidneys. So patients who already have damaged kidneys should not receive tenofovir. So we simply switch it for AZT, which does not have that side effect. Okay. Regimen 2 for adults is Kaletra or Aluvia now. Most people know it by Aluvia. 3-TC and AZT. And so that's for patients who fail regimen 1. For children, the new regimens are abacavir is changing again for the D4T. The D4T. Okay. So we've changed abacavir for D4T in your first line regimens. Okay. For children. The others remain the same. So for children less than 3, remember it's 2 NRTIs, abacavir, lamivudine, plus something else. And for children less than 3, there's something else, is a protease inhibitor, Kaletra or Aluvia. For children over 3 years, they're same 2 NRTIs, plus they use Stoker. So now we're going to talk a little bit about the medicines. This is a bit of a review. I know we talked about this, I think, in the side effects lecture. All right. So D4T, it comes in a tablet for adults. For children, it can be opened, mixed in water, and dissolved. Is a very good medicine. It works very well for HIV, but it also has a problem with toxicity. The more you take of it, the more stavudine you take, the more likely you are to develop these side effects. So the higher the dose, the more likely you're going to get side effects. The longer you take it, the more likely you're going to develop side effects. So there's problems with it. There's problems with it. Okay. The main side effects, lipodystrophy, lactic acidosis, peripheral neuropathy. All of these big three side effects of stavudine. Now it is no longer part of initiating regimens for adults or children. So all new initiations should not be taking this. Patients who are already taking it and doing fine and have no side effects, they continue. There are certain people, though, you might actually want to switch even if they have no side effects. And those are the people that are at high risk of developing toxicity. And those people at high risk are those that are obese, so have a high BMI, older females, and if they're also on TB treatment. The new South African guidelines tell you you can actually switch even if there's no toxicity if they have one of these three, and particularly if they have more than one of these three. So if you have an obese, elderly female who's on TB treatment, I would switch her to tenofovir if her creatinine clearance is okay. So the current guidelines say that they remain on treatment unless they're fine. Any signs of toxicity, switch to tenofovir or bacavir for children. Or if they're at high risk for toxicity, you are also free to switch them. Lamivudine, 3TC, it comes in a syrup for children, tablet for adults. For older children, this tablet is scored. It can break it in half for a 75 milligram dose for older children. Adults can take, particularly with the new regimen of tenofovir, which is a once-a-day medicine, Stokrin, which is a once-a-day medicine. If you actually take 2 tablets of lamivudine at the same time, you can actually take lamivudine once a day. So most people who I initiate these new regimens on, I tell them that they can take their medicines once a day. They simply take all of them at once, usually at nighttime because most patients like to take their Stokrin at night. So they take 1 Stokrin, 1 tenofovir, and 2 lamivudine at nighttime, and that's all they need for their ARVs. Tenofovir is a new part of the new guidelines, a new medicine in South Africa, and it was added to the repertoire because of its improved side effect profile. It's very, very low side effects with tenofovir. It's new first line for adults, or also used for those who are having toxicity or at high risk for toxicity in patients taking stavudine. The main side effect it can cause is kidney problems. And that's why we need to monitor kidney function through this test called a GFR, glomerular filtration rate, or creatinine clearance. So it's it's not a test that you can just measure, you have to calculate it. So a lot of people, particularly doctors in very busy clinics, are resistant to do this because it does take a few minutes to do. But it's still important in patients who are going to be taking tenofovir or are already on it. So the current guidelines say to take the creatinine at baseline at 3 months, 6 months, and then every 12 months. It can also cause osteoporosis, which is thinning and weakening of the bones. This is particularly the reason for children not taking tenofovir until they're skeletally mature. So it's actually not licensed for children under 18 years of age. You can use it in extreme circumstances, and it has been studied in children, I think, as low as 12 years of age, but it's still not licensed until for children less than 18 years. So this is my simple way of measuring the creatinine clearance without doing the long and fancy calculation. If the patient's age is less than 50, if their weight is over 50 kilograms and their creatinine is less than 100, then their creatinine clearance is fine, and they can safely start tenofovir, and you can put your calculators away. So, and it's very easy to remember because it's 50, 50, 100, right? 50 plus 50 equals 100. So if their age is less than 50, their weight is over 50, and their creatinine is less than 100, tenofovir is safe for them, and it's not going to be a problem. Okay. Stokrin has certain side effects as well. It comes in one large capsule for adults and 2 different sized capsules for children. It can have side effects. About half the people who take it have some sort of side effect, particularly in the first few doses. And it can be minor, like dizziness or bad dreams, hallucinations, those sort of things. This is the main reason why we give it at night, because it can cause drowsiness, sleepiness, not feeling right. So if you give it right before or soon before they're going to go to bed, it's usually not a problem. Does Stokerin have to be taken at night? No. Does it not work if you take it in the day? No. And as I said, half the people don't have any side effects whatsoever. And if patients do develop side effects, over 95% of them, they're gone by 2 weeks. So could you switch then to a daytime dose after 2 weeks if you're not having side effects? Absolutely. There's no reason not to. No reason not to. This is the drug that's highly recommended for patients on TB treatment, okay? Because the drug-drug interactions are the lowest. There are drug-drug interactions with most ARV medicines and TB medicines, but Stokerin actually has the lowest. It can also cause a rash in patients, similar to nevirapine, not as common as nevirapine and usually not as severe as nevirapine. Stokerin also has listed as a side effect of causing potential birth defects. And it can cause spinal form malformations in children, at least potentially. So it should be avoided in the first trimester. After the first trimester, the spinal cord and spinal column is already formed. So there's no reason not to take Stokerin after the first trimester. There's really no reason. And there's growing bodies of evidence and many reviews of the literature which is actually showing that it actually may not cause many birth defects. And if it does, the incidence is extremely low. Extremely low. Efavirenz or Stokerin can also cause what's called gynecomastia, which is the development of breasts in men, which you've probably seen in the Sowetan recently and on several news programs. Gynecomastia is best if it's caught early. If men start to develop swelling of the breasts, and this can also be a side effect of lipodystrophy from stavudine, but you can simply switch their treatment and it usually resolves. And oftentimes it actually resolves on its own anyway. But if it's not resolving, then switching the treatment does help. Nevirapine also has side effects. Its main 2 side effects are rash and liver damage or hepatitis. The rash can be quite severe, causing Stevens-Johnson syndrome, which you'll see pictures of during the toxicity lecture. And it can involve the eyes, the lips, the genitals, and it can be pretty severe and even life-threatening. The same is actually true of the hepatitis. That can actually be very severe and can be life-threatening. Okay? The people at highest risk of hepatitis are actually pregnant women with high CD4. CD4 is over 200, or 250. Actually receives nevirapine. Pregnant women, most of them with CD4 is over 250. So you actually are putting them on high risk. Okay. So outside the first trimester, Stokerin is safe. It is safe and can be used. The old South African guidelines used to say that. The new South African guidelines say use nevirapine for all pregnant women. I don't think there's a lot of evidence to support that. Particularly because most pregnant women present to the clinic very late. Not just late, but very late. And the sooner that we can get their viral load down, the better and less likelihood of passing the infection off to the child. The problem with nevirapine is it has a lead-in dose. So you take half the dose for 2 weeks to make sure you're not having side effects. And then take full dose. So it's slower to drop the viral load than it is to take Stokerin. So particularly women late in the 3rd trimester, although the guidelines don't tell you to start Stokerin, I usually do. And I usually recommend women taking Stokerin at that point. Here's a few pictures of nevirapine rash. It can be a very mild, itchy, bumpy rash that is fine to continue treatment. Patients with this similar rash, you can give them symptomatic treatment with antihistamines and topical anti-itch medicines. Again, this one is becoming a bit more severe, but again, these patients can continue unless it involves severe rash involving the lips, eyes, and genitals. AZT, a very good drug, actually the first drug that was ever made for antiretroviral therapy. It also has a few side effects, mostly related to the blood. It can cause anemia, low white blood cell count, and low platelets. This can also cause lipodystrophy, lactic acidosis, peripheral neuropathy, but much, much less common than D4T. DDI, we're actually steering away from. Adults, it's no longer part of second-line treatment. For children, it still is. But it's difficult to give. It must be taken on an empty stomach. You must take at least 2 tablets to neutralize the acid in the stomach. It can be taken once a day for adolescents and adults, but children, we're still not sure whether it can be taken once a day. So we still recommend twice-a-day dosing for young children. It also has a lot of side effects, actually even more side effects than D4T. It can cause pancreatitis, peripheral neuropathy, and lactic acidosis. If you use D4T and DDI together, there is very, very high chance of getting severe side effects. So only in very, very rare circumstances would you use D4T and DDI together, really, unless you had no other options. Kaletra or Eluvia is first line for children less than 3 or second line for older children and adults. It comes in these capsules of Kaletra, the capsules of Eluvia, which is the formulation we're now using, and it also comes in a syrup for children. It's actually a very strong medicine. It's harder to make resistance in this drug because if only one screw changes, Kaletra can still work. You need to change multiple screws. It needs to have multiple mutations for Kaletra to not work. So Kaletra is kind of like one of those screwdrivers where you can change the heads of it, right? So it'll fit a couple of different places on the enzyme. So it can work even if there's a few mutations. So it's actually stronger than most medicines, which is why it's used for second line. That's the main reason it's reserved for second line. Because patients who've already gone through first line have a lot of mutations already. So if you take Kaletra, you're likely to be suppressed, and it's harder for it to become resistant to Kaletra. It does have some side effects. Usually, a good portion of patients do develop diarrhea, particularly in the first week or 2 on treatment. So it's good to counsel them that they may have that, but usually by 2 weeks, the diarrhea has subsided. There are also long-term side effects of Kaletra, like diabetes, like elevated cholesterol, elevated triglycerides. So heart disease and diabetes need to be screened for in patients taking long-term Kaletra or Eluvia. The solution is stable at room temperature for younger children, although it does taste pretty disgusting. Those of you prescribing it to children, I would recommend tasting a little bit of it so that you know what the children and what the parents and caregivers have to deal with in trying to get the children to take it. It does taste very, very, very bad. Abacavir is new first line for children. It comes in tablets. It also comes in a syrup. The main problem with abacavir is one of the side effects, which is a hypersensitivity reaction. It's like an allergic reaction. In studies, it's shown to occur in about 5 to 8% of children and adults. It's said to occur less in African populations. There's a particular genetic susceptibility to this side effect, which is said to occur less in people of African descent. However, now that there's more and more people and more children getting on this, we may start to see more of this side effect. We've actually already seen quite a few of them in children in the first few months that we've had abacavir. So what is the hypersensitivity? Well, it's basically an allergic reaction. Children can get fever and rash, which are the most common symptoms, but they may actually not even develop rash and still have this. The problem is usually not the first episode. It's if you stop it and then re-challenge them with it. And that can actually be fatal. So patients who develop abacavir hypersensitivity should stop abacavir, and they should never again take abacavir. Okay. Any questions? I knew there was a question in the back, but I just wanted to get through the medicines. Is there any questions till now? Sorry? Instead of taking Stokerin at night? So I still didn't. You take it in the morning with Bactrim. Is that what you said? Uh-huh. Uh-huh. Yeah, it's fine. It's fine. It's fine. So the question is, can you take Stokerin in the daytime at the same time as you take your Bactrim? That's perfectly fine. Bactrim actually doesn't need to be taken every day either. It's not an ARV. It works against the bacteria. And actually, if you take Bactrim 3 days a week, it works just the same. Works just the same. And there is really no drug-drug interaction between Stokerin and Bactrim. The only reason we recommend taking it at night is because of the side effects, which are particularly early on in the treatment. Another question? Question? No? Yes? No? Yeah, yeah. So if a patient has lactic acidosis and are on D4T, you need to stop all of the ARVs until the lactic acidosis comes down and resolves itself. And once it's resolved, then you can restart ARVs. We're going to talk about that in the toxicity lecture, though. Okay. All right. In the interest of time, I'm going to move on. We'll have questions, time for questions at the end. Okay. So I wanted to talk about adherence. We're actually going to have a whole lecture on adherence later on, but this is just a few slides as an introduction about adherence. So why is adherence so important? Well, we saw a little bit about it in the beginning of this lecture with our HIV virus dots, right? But this is actually another good example of why adherence is so important. So this graph shows what's happening in the blood to somebody who's taking an ARV. Right? So they take a dose now, and it takes time for the body to absorb the medicine, right? And so the drug levels go up. And then over time, you reach a peak, and then the drug level slowly starts to come down. And so a time period where you take the next dose, right? And then what happens? The blood level comes up, reaches a peak, and then slowly starts to come down. So we want to take the drug at regular intervals so the drug levels stay nice and steady in this range. Now, every medicine has a certain range. Too low, and it doesn't work. Too high, and you get toxicity and side effects. So we want it to stay in this nice range, right? And so that's why patients need to take their drugs on time every day. But what happens if they don't? They take their medicine, say they take their medicine once a day now. Now we're taking our medicine once a day. And they take it today, It comes up and it reaches a peak midday. At night it's coming down, it's coming down, it's coming down. They should have taken this dose here, but they missed it. They forgot. So what happens to the drug in the blood? It's down, 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 right? And soon, if they don't take it, we're going to reach a level where it stops working, right? And if it stops working, there's chance of resistance. How is there chance of resistance? Well, because the virus wakes up, right? It's at too low of a level from stopping the virus from making more of itself. So what does the virus do? It makes more of itself, makes more of itself, and makes more. Now, which viruses are going to make more of themselves? The regular old virus, or if there happens to be a virus where there's been a change. Yeah. If there's already a change, because remember there's still some of the medicines floating around, right? So it should keep some of the weak viruses still down. If there's no mutations, it might still be keeping them down. But if there's a few around that have had mutations, who's going to be the first to wake up and make more of themselves? They will, right? And so what do? Make more of themselves, make more of themselves and more of themselves. The viral load goes up. The viruses, the stronger viruses, the ones that weren't being inhibited as much, are the first to wake up and make more of themselves. And now we have a chance of resistance, right? So we have our virus. It makes more of themselves. Those viruses make more of themselves. Those viruses make more of themselves. And so if we take 3 drugs, but we've been missing doses, what happens? There might already be resistance. Because they were late with drugs, missing doses, we couldn't develop resistance. So those viruses make more of themselves. Those make more of themselves, and so on. So guess what happens? The train was stopped and backed up. We start the train back up. We're going down the hill. We're heading towards the track. The viral load is increasing. The CD4 is decreasing. We're resistant. And even if we go back to taking our treatment, train's not stopping. Might slow down for a little bit, but then it's just going to keep on going. It's going to keep on going. Towards the edge of the cliff, the CD4 will decline. You're at risk of getting an opportunistic infection and dying. Okay. So, the patients are no longer stopped. They're back on the pathway of declining CD4. The viral load is increasing. Soon they'll get symptoms, opportunistic infection, and die, even if they're taking their medicines properly. If there's resistance, this happens, continues to happen. Okay. So what do we mean by adherence? Well, we mean storing the medicines properly. It means taking the medicines every day, not missing doses, taking them on time, usually within 2 hours. Now, a lot of patients freak out sometimes to me. You know the patient's very good when you say, how are you taking your medicines? Are you missing doses? They say, oh, doctor, it was terrible. Last week, I took it at 8:15. I'm supposed to take it at 8. So you know what? That's fine. Because there's a little bit of leeway, right? In that graph, it's not, you don't take it right as it hits the bottom, right? There is a little bit of leeway. And that leeway is about 2 hours. Okay, so if patients are 15 minutes late, it's not a problem at all. If they're an hour late, starting to be maybe a problem. 2 hours late is definitely a problem. But if it's 15 minutes, if it's a half an hour, it's not a problem. It's not a problem. Okay? Also following food restrictions with some of the medicines. As we said, the original formulation of Kaletra and the liquid formulation of Kaletra in children needs to be taken with food. DDI needs to be taken on an empty stomach. So without these things, the medicines don't work as well as they should. Okay. A little bit about switching treatment, because we don't actually cover this very much in the lecture, except in the course, except during the resistance lecture. So when do you switch treatment? It's currently recommended if a patient has a viral load over 1,000, and you have AZT-based first-line regimen, then they take D4T, 3TC, and Kaletra. If they're on a tenofovir-based first-line regimen, so the patients who've been initiating since April 2010, then they switch to AZT, 3TC, and Kaletra for adults. Of course, you must make sure adherence is good. Maybe their viral load was high because they weren't taking their treatment. That's not resistance. That's not resistance. Resistance is when you're taking the treatment on time, every day, good adherence, and yet the viral load is still elevated. Patients who are failing second-line regimen, well, unfortunately in South Africa, there's no third line. There's nothing else we have. So patients who are failing second line, then they really need to see a specialist and see if there's something else that we can do. There's some patients who can get enrolled in a resistance study. There are research studies going out with some new medicines that are available in a research setting, so we may be able to get them on that. But really they need to be referred to a specialist center and a specialist to see what it is that they're doing. And I can tell you pretty confidently, patients who are failing second line, or patients who are failing Kaletra-based treatment, probably 90% of the reason that they're failing is they're not taking it. The only other reasons sometimes happens is if there's drug-drug interactions, particularly TB treatment. TB treatment plus Kaletra, and if you don't do something about changing the dose, or adding ritonavir, or switching the treatment, can cause resistance. But that's the minority of patients. The number one reason for patients failing Kaletra-based treatment is they're not taking it. Okay. So switching from first line, as I said, it's 2 viral loads of over 1,000 separated by 3 months. After you've checked and improved adherence, you've intensified adherence counseling and monitoring. Okay, so they should have stepped up adherence. They definitely need to have either pill counts or pharmacy checks. Some sort of adherence intervention needs to be done, because if they're not taking the medicine, second line's not going to help. Okay? Medicine only works if you swallow it. Second line doesn't work by sitting on the table. All right? Just as first line doesn't work if it's sitting in the bottles. Very, very, very important now, particularly. This should have always been the case, but is now in the new guidelines, and a very important aspect about switching treatment is patients with hepatitis B. Patients with hepatitis B, they're actually taking medicines for it if you're taking HIV medicines and have hepatitis B. Because tenofovir and 3TC both work against hepatitis B. So that's another great reason for taking tenofovir, is for the hepatitis B patients. And I recommend screening, if you know any patient who's hepatitis B positive and they're still taking D4T, they should switch to tenofovir. That's another reason I didn't put up there, but that's a very important reason to switch them to tenofovir. Is because it's active against them. The problem is, if they're hepatitis B, taking 3TC and tenofovir, and you stop it, the hepatitis B can wake back up, just like stopping ARVs. But when hepatitis B wakes up, it can become very aggressive and can lead to a very aggressive and potentially fatal hepatitis. We call it a hepatitis flare. So if patients are hepatitis B positive, we do not stop their tenofovir and 3TC. Okay? I would seek specialist advice, but we'd probably just add Kaletra onto the regimen, maybe an additional medicine like AZT. But we wouldn't stop their tenofovir and 3TC. So it is very important, before you stop a patient's treatment or switch a patient's treatment, you need to know whether they're hepatitis B positive or negative. Okay, and there's a few words about nutrition. Again, this is a lecture that you're going to be watching later, but a few important points about nutrition. So, as I said, there are certain medicines that have food restrictions. Kaletra, when it's called Kaletra, needs to be taken with food. Alluvia, the new formulation, actually does not. But the syrup of Kaletra for children and the old sort of orange gel capsule formulation of Kaletra needs to be taken with food to absorb it properly. DDI needs to be taken on empty stomach. Everything else really doesn't have food restrictions. And that includes, and I don't have it up there, but tenofovir and abacavir also do not have food restrictions. And I really want to emphasize that there is no diet to cure or really improve HIV, which has not been the focus in the years past, has it? I think in years past, nutrition was sort of promoted as, in some cases, a cure for HIV, and in other places, well, at least it can delay your development of HIV disease and symptomatic HIV. That's actually not true. There really is nothing you can eat to delay that process. But it is true if you're malnourished and starving, you progress faster in terms of HIV. But that's a very low percentage of patients. You see it much more in children than in adults. But it's not like saying, well, you're HIV positive and you're going to progress fast because I see you eating Wimpy twice a week. No. You know, and you're eating at KFC. And so that's not, we know that's not a proper diet, so your HIV is going to progress more. That's not true. That's not true. Of course, it can lead to other health problems, heart disease, high blood pressure, high cholesterol. But in terms of HIV, it really does not impact the disease unless you're malnourished. So, contrary to what the previous Minister of Health used to say, beetroot, lemon juice, garlic, olive oil, African potato. Well, actually, most of these things taste very nice. I like to put a little olive oil and garlic on some of my food. They taste fantastic. But they don't do anything for HIV. And that includes Bijani, traditional medicines. You go to the Muti market and they can sell you all sorts of things for HIV. But they don't work. They don't work. And you say, how? Well, then how is that possible? Right? How can they sell you this if it doesn't work? How come people take it if it doesn't work? Well, they're not effective in improving the health status of an HIV-positive patient unless you're starving and malnourished. Then, of course, eating a proper diet, getting them out of starvation, getting them out of malnutrition will help prolong their life. So you say, how is that possible? How can somebody sell me immune boosters? How can somebody sell me something, traditional medicines, that don't work? Because the people selling it are very, very clever. Because they're taking advantage of clinical latency. We know that in 80% of patients, or really 90% of patients, by the time they get infected to the time they get sick,